For decades, Rhesus isoimmunization was a major cause of fetal mortality. The pathology is a direct immunological conflict. The maternal immune system identifies fetal red blood cells as foreign, mounts a targeted antibody response, and destroys them. The root of this conflict lies in blood genetics. The Rhesus system contains over 40 distinct antigens, but clinical management hinges on just one, the D antigen. Its presence or absence strictly dictates whether a mother is classified as Rh positive or Rh negative. For hemolytic disease to develop, 3 specific stages must occur. It begins with an initial genetic prerequisite. An Rh negative mother must conceive a baby who inherits an Rh positive phenotype from the father. The second stage requires a physical breach. During events like miscarriage, prenatal testing, or delivery, feto-maternal hemorrhage allows Rh-positive fetal cells to cross the placental barrier. The mother's system detects the B antigen and mounts an immediate immune response. This leads to the final, destructive stage. The mother begins generating permanent IgG antibodies. Because of their small size, these maternal antibodies cross back through the placenta, bind to the fetal red blood cells, and trigger widespread immune destruction, a process known as fetal hemolysis. Because this cascade poses a severe threat to the fetus, modern obstetrics structures the entire management of an Rh-negative pregnancy around a single critical physiological checkpoint: maternal sensitization. Sensitization is the exact moment the maternal immune system irreversibly learns how to produce anti-D antibodies. Early blood tests identify this, splitting the pathway into non-sensitized and sensitized tracks. In the sensitized track, the focus shifts entirely to early detection and direct treatment of the fetus. For the non-sensitized track, clinicians must use aggressive immunoprophylaxis to maintain the mother's status. Because the immunological memory of sensitization cannot be erased, primary care on the non-sensitized track relies entirely on executing precise prophylactic interventions before the maternal immune system can react. The standard prevention protocol for a non-sensitized woman begins with vigilant surveillance. Antibody screenings are conducted at 20, 24, and 28-week marks to confirm she remains unsensitized. Prophylactic anti-D immunoglobulin, commonly known as RhoGAM, is administered routinely at 28 weeks and again within 72 hours of delivering an Rh-positive neonate. Anti-D acts as a molecular shield. The administered antibodies actively hunt down any fetal red blood cells in the maternal bloodstream, binding to them and neutralizing the foreign antigens before the mother's immune system has the chance to detect them. This chemical intercept has strict volumetric limits. A standard 300 microgram dose of RhoGAM provides enough antibodies to neutralize a maximum feto-maternal hemorrhage of 30 milliliters of whole blood. If a physical trauma or complicated delivery causes a bleed exceeding that 30 milliliter threshold, the standard dose will fail. To catch this, clinicians rely on a mandatory safety net, the Kleihauer-Betke test. The Kleihauer-Betke test leverages a unique physiological trait. Fetal hemoglobin is resistant to acid, while maternal hemoglobin is not. By applying an acid wash to a maternal blood sample, the maternal cells lose their pigment. Clinicians can then count the remaining brightly colored fetal cells to calculate the exact volume of the hemorrhage. Preventing Rhesus disease requires mathematically proving that the volume of the prophylactic dose matches the precise volume of the fetal bleed. If prevention fails, or if a patient arrives at booking with detectable alloantibodies, she enters the sensitized pathway. Her immune system is already actively attacking the fetus, making early detection of fetal anemia the sole objective. The initial monitoring strategy relies on checking the mother's serum antibody titers every 4 weeks, tracking the concentration of anti-D in her system. However, this metric has a critical failure point. Once maternal antibody titers reach a specific threshold, typically greater than 64, or a significant 2-tube dilution rise between samples, the numbers lose their predictive value. At this high concentration, the maternal titer no longer correlates with the actual severity of the fetal disease. This creates a clinical paradox. The medical team needs to measure how rapidly the fetus is losing red blood cells, but obtaining a direct fetal blood sample is highly invasive, carrying a risk of triggering further hemorrhage and worsening the very sensitization they are trying to manage. Reaching that critical antibody titer forces the clinical strategy to pivot. Maternal blood tests are abandoned entirely in favor of direct physiological surveillance of the fetus in utero. The modern gold standard for this direct surveillance is the middle cerebral artery peak systolic velocity, or MCA-PSV ultrasound. The MCA-PSV relies on basic fluid dynamics. As fetal red blood cells are destroyed, the viscosity of the blood drops. To maintain oxygen delivery, fetal cardiac output increases, meaning the thinned blood rushes faster through the brain's arterial system. Clinicians measure this velocity. If the speed equals or exceeds 1.5 multiples of the median for that specific gestational age, it serves as a highly accurate diagnostic threshold for severe fetal anemia. Before high-resolution ultrasound, tracking this destruction required amniocentesis. Clinicians would draw amniotic fluid to run a spectrophotometric analysis, measuring the exact concentration of bilirubin, the chemical byproduct left behind when red blood cells are destroyed. This chart shows the Liley graph, used to interpret bilirubin concentrations. Plotting optical density on the y-axis against gestational age on the x-axis quantifies the damage into 3 zones. Landing high in Zone 3 signals catastrophic red cell depletion, impending hydrops or death. Whether tracking the physical velocity of blood through the brain or the chemical concentration of bilirubin in the fluid, crossing these exact mathematical thresholds dictates the moment clinicians must trigger end-stage surgical intervention. An MCA-PSV greater than 1.5 multiples of the median, or a bilirubin reading deep in Zone 3, immediately triggers the need for an intrauterine transfusion. Before blood is transferred, a highly precise fetal blood sample is drawn. This confirms the exact packed cell volume, allowing the medical team to assess the true depth of the anemia. The modern procedure of choice is intravascular transfusion. Using continuous ultrasound guidance, a needle is navigated through the amniotic cavity to pierce the umbilical vein, aiming to rapidly elevate the fetal packed cell volume to between 40 and 50%. By injecting the blood directly into the fetal vascular system, clinicians achieve an immediate correction of the anemia, resulting in an 87% survival rate for severely compromised fetuses. This intravascular approach has largely replaced intraperitoneal transfusion, an older method now held in reserve as a secondary option for technically difficult cases, such as when a posterior placenta blocks direct vascular access. Intraperitoneal transfusion is significantly slower. Blood is injected into the fetal abdominal cavity, requiring the fetal's lymphatic system to slowly absorb the red cells into the bloodstream, a process heavily dependent on active fetal respiration, taking weeks rather than minutes. Directing donor blood straight into the fetal vascular system is technically difficult and carries a severe risk of triggering further maternal hemorrhage. Yet, despite these risks, it remains the single most reliable method to immediately halt and reverse catastrophic immune destruction in real time. The biological specifications for the donor blood used in these transfusions are extremely rigid. The blood must be strictly O-negative, negative for cytomegalovirus, must be leukocyte depleted, and densely packed to maximize oxygen delivery without causing volume overload. Crucially, the blood must also be irradiated. This disables any remaining donor white blood cells, ensuring they cannot initiate a graft versus host attack against the already compromised fetus. In many cases, clinicians prefer using washed maternal red blood cells. By utilizing the mother's own O-negative blood, they ensure no new, unrecognized antigens are introduced to the fetus, while providing cells that maintain a longer circulating half-life. Implementing this bifurcated management strategy, pairing vigilant prophylaxis with precision fetal transfusion, dropped the incidence of Rh sensitization from 16% to under 2%. By identifying the genetic mismatch early and neutralizing the specific antigen breach, this methodology has shifted a once fatal immunological cascade into a manageable clinical condition.